After such a wonderful start, I'm delighted to continue the second session of the day, during which we have 4 wonderful presentations. And the first one will be by Helene Speyer, who got up at 4 in the morning yesterday to take a short flight from Copenhagen and arrived here at 1 o'clock in the morning in a taxi that did not accept her visa. And she made it all the way here without her suitcase. And and so I'm sorry about the long and winding road, but glad that you're here with us today. A few words. Dr. Helene Speyer is a licensed psychiatrist and associate clinical professor at University of Copenhagen. She received also a PhD in clinical psychiatry from University of Copenhagen, where she also got her medical degree and completed her residency training. Dr. Speyer has worked in a variety of clinical settings, including hospitals and community mental health centers. She specialized in early psychosis and recovery-oriented mental health care. Her current research focuses on the development of guidelines supporting shared decision-making for antipsychotic dose reduction. She is a member of the Danish Psychiatric Association Research Group and serves as a member of the steering committee at the Center of Evidence-Based Practice in Psychiatry. Thank you so much for being with us today. And a little slow also.
Yes, hello, and thank you for the introduction. You've got to say that as my suitcase is missing, I'm wearing David's wife's dress.
I don't know how much to disclose.
And with that said, so is that a good place? And as David said, I have been engaged in what we can call de-prescribing research for some years, and I have been giving I have been giving hundreds of presentations about research. But today I'm going to do something that I have never been done before. I'm going to share with you my personal history of living with mental distress. And I'm not going to pretend that it's easy. And I don't even think that my history is specifically interesting, but it's my story. And I kept it to myself for many years, even to my close colleagues. But when I started talking about it, it occurred to me how much impact it had had on my way of understanding mental health and illness. And it's not a revenge, it's not a bad story. It's maybe a little messy story. And I've come to think that it may at least partly explain why I find myself disagreeing with my colleagues very often. But you can decide for yourself if that's a meaningful way to understand it. As David said, the topic on antipsychotic discontinuation or continuation is a heated debate. And when we present the research that we do, people, both clinicians in Denmark and internationally, they're like, why? Tapering, reduction, why are you not researching adherence? And I think most voices in mainstream psychiatry, they find de-prescribing research to be immoral, that we have an ethical obligation to focus our research on adherence, and because they see that adherence to medication is what leads to the best outcome in people with psychosis, and that's where we should focus our scarce resources. And I disagree on that. And when I talk to people about the debate, we refer to the same body of evidence. So we need to go a step further down to understand really what the debate is about. And I've come to think that the divergent views on the topic can be understood as different philosophical assumptions. And it's a bit heavy, but we all have some philosophical assumptions about how the world is. which is the foundation of our research. And I think they can be understood as ontological assumptions about what kind of things are these mental disorders, epistemological assumptions, how we can acquire knowledge, and normative assumption about how we should practice psychiatry. And I think that what happened to me was that these very basic assumptions, they started to change. And that made me have this position in the debate where I am more critical to medical treatment than most of my colleagues. And now I will do this extremely terrifying thing and share my story. A little water? Thank you. And the reason why it's so difficult is, of course, I think you all know that it's scary because maybe people don't want to work with me, maybe they lose trust in me and all that kind of stigma stuff. And being a psychiatrist does not make it easier. But my story is I grew up in Norway. I live in Denmark now, but I grew up in Norway just outside Oslo in a small town with my parents and my baby sister, and it was a very warm and loving family. I can hardly imagine a better place for a child to grow up. But when I entered the summer when I was 13 years old, I entered with all the joy and anger and opposition and excitement that should be in a 13-year-old body. But something happened. And it didn't happen to me, it happened inside me. I'm not traumatized at all. But I was struck, and it happened very fast, without any warning signs. I remember where I was when it happened. It was a fear and anxiety I couldn't imagine before it happened. And it wasn't like a panic attack. It didn't go away again. It stayed inside my body. And I was sad, fearful, and a darkness that just wasn't like it used to be. And after a few weeks, I developed some strange beliefs about other people. And I stopped seeing friends, I stopped going out. The worst periods, I couldn't even go into the garden. I played the piano, and that was about it. And my increasingly desperate parents tried to talk to me, tried to convince me that these beliefs I had, they were wrong, but I didn't feel disordered at all. I felt sorry for my parents because I waited for them to realize very soon that my reality would be the correct reality. And after a while, I think they gave up, and then they tried to convince me to see a psychiatrist, which I refused because I did not feel disordered. So why should I see a psychiatrist? It was just this crazy thought they had about me. They conspired with my beloved school teacher, and then I decided to go one time. And that one meeting with the psychiatrist was a turning point for me. I did not meet a man who was specifically interested in my beliefs. He didn't talk about my beliefs, or my fear, or my sleeplessness, or me not going out at all. He talked to me about life. And he talked to me about how, or he didn't say it, but I think he very slowly and very gently pushed me back into normal life without ever labeling this thing something. It didn't have a name, and it didn't occur very interesting to him. So I didn't feel wronged. I didn't feel like I was diseased. I just liked him a lot. And I felt so safe when I had been with him. And very slowly I returned to my regular life. But absolutely transformed, of course. I didn't go back to where I had been, and I think when when people and adolescents have faced this kind of darkness and despair, going back to normal puberty is very difficult, because the things that you care about in puberty just didn't make sense anymore. I was another place, a very severe place, but slowly going back to life. And life was good. Symptoms never completely disappeared, but I could continue life. And I went to medical school, and I decided to be a psychiatrist. But before I made that decision, I had 2 kids, and I got divorced. And after that divorce, something happened again. I developed severe sleep problems. And I reached out to psychiatry, because now becoming a doctor, I thought that was the way to go. And to my surprise, they admitted me to a psychiatric ward. I found myself there. And for those of you who haven't tried it, it's the strangest thing ever. It was so quiet. And even though that there were other patients than me, nobody talked. The nurses didn't talk, we didn't talk. It was just so quiet. And I felt so estranged. And I remember it as almost as a derealization experience. It was dark, but still the light was very sharp. And the only thing the nurses said was, "Do you need another sleeping pill?" And I quite fast discovered that this is not the place for me to recover. And I had my childhood experience, that I had been given the agency and I had felt empowered. I had the experience that I could get on with life without the mental health care system. So I did. I went home, told the psychiatrist I'm fine, and I left. And that worked for a while. Good. And the next thing that happened, now as a trainee in psychiatry, I had a meeting with my supervisor, who I really liked and respected and trusted. And we happened to discuss my own struggles. Now these are, of course, only snapshots of my struggles that has been going up and down for my whole life. And before I left that room, she had diagnosed me with bipolar disorder and made a prescription of aripiprazole. And she said, and I know she meant it really good, she said, "I'm not going to make blood work or ECG, I'm not going to make a health record, because it's better for you that nobody can find out about this." So actually I got a very bad treatment, because nobody should find about this. And that was almost as strange as being admitted to hospital. I went home with these pills and told my then boyfriend about the diagnosis, and he just got up and left. I never saw him again. And I tried to take these pills, and all of a sudden I found myself seeing and understanding myself through this prism of bipolar disorder. Everything that had happened in my life so far, I saw sign of bipolar disorder. And I can relate to Pat Deegan's comment about it's like it's over. I really couldn't figure out how life should go on. And I was actually in a good place at that moment. I had some sleep problems, and I had maybe something with the mood, but it had been much worse. And after quite a short time, I stopped taking medication without telling anybody, so-called against medical advice. I didn't have a psychiatrist, so I didn't have anyone to ask. And I never took them again. So to sum up my own history, as I understand it now, it's a history about different conceptualization of mental distress and how I experienced these different ways to understand me. And I will quote the writer in the New Yorker, Rachel Aviv. She says, "There are stories that saves us and stories that traps us." And I really believe that the very first psychiatrist I met, he told a story about me that saved me. So I'm very grateful for him for doing that. You probably know him. And now the interesting question for me is, how has this story shaped the way I practice medicine and research today? And I started to talk about these basic assumptions about how psychiatry should be practiced. And in the beginning, during my first years of training, I did a very good job. I was such a good pupil, and I never questioned these basic assumptions. And I remember saying to people, or educating people, that you have this disorder, and it's called this and this, and probably genetic, we don't know, but it's caused by an imbalance in your brain. I said that. But the good news is we have this medication, and then we can fix your imbalance, and you should be hopeful, because there's hope for people like you. And I got promoted and promoted and promoted again, and was even headhunted to do a PhD. And I thought, I'm doing good. But there was something that felt wrong. And I think that it was called cognitive dissonance. I was meeting people in a way, but still feeling so immensely grateful that I had been met in a completely different way. So I did what I think most people do when they have this feeling of cognitive dissonance. I started reading. First, I started reading about medical statistics because I wanted to test these claims. Is it really so that we can say that these things are caused by biochemical imbalances? We need to know something about statistics to reject or confirm that hypothesis. And when I had finished reading about medical statistics and could say, well, I think we have been lying, not very much, but we are lying when we tell people this simplistic story. And then I started reading about philosophy of psychiatry. And that's where I met these basic assumptions about the field. And it occurred to me that the basic assumptions that I had been trained in implicitly were that psychiatric disorder, they are discrete disorder, natural entities that can be found in the real world, and they are caused by some brain dysfunction. And the normative assumption was that I, as a psychiatrist, I'm the expert, and I have an ethical obligation to protect people against making the wrong choices, which is to not take medication, because they have these vulnerable brains, and having more symptoms will make their prognosis worse. So I had bought into that way of thinking. And then in my reading, I discovered if they are just assumptions, they are not scientific, they are just philosophical assumptions, some like rules we have to make for ourselves to make this field work. And then I discovered that there are other fields who also study psychiatry, and they have different rules, different philosophical assumptions. And then I changed my philosophical assumption, going from this biomedical reductionistic paradigm to say maybe it can be conceptualized as something else than a disorder. Now my cognitive dissonance started to wane, because now I could understand my own history. And I started to think that a pluralistic approach is probably better at the moment. And regarding the normative assumption, I stopped thinking about myself as the expert with an obligation to make people behave in the right way, and started to think that it's my obligation to present my expertise, my knowledge, and then to support people in what they choose, in how it's meaningful for them to conceptualize their experiences and how they find it's useful to recover. So in a way, I changed from being a mainstream psychiatrist to be what I now know is a more recovery-oriented psychiatrist. And I'll borrow a little bit from Kuhn, the philosopher of science. He says that through periods of normal science, the basic philosophical assumptions are implicit. We don't talk about them. It's just the rules that we have agreed that this is how we see it. But then when paradigm shifts are approaching, then there's a sign, and that is that we are increasingly discussing philosophical assumptions. And I think what happened inside me was a very small Kuhnsk paradigm shift, where I got increasingly engaged with all this philosophy and had nobody to share that with because it's not really a hot topic. But I think that's how I understand that part of the story. And to connect to the topic of this workshop, which I find very important, of course. My research now is about making these clinical guidelines to qualify the shared decision-making process. So the idea is that we provide knowledge in a way that's important and comprehensible for all around the table. And I think another point is very under-researched, and that's how we taper medication in order to make it as safe as possible. And I'm not always thinking that it's a good idea to taper medication, but I'm always thinking that if my patient chooses that way, it's my obligation to support him and make that process as safe as possible. So I have gone from thinking that we need to protect people from relapses to thinking it's a human right to get support if you want to get off medication. We can't, many of my colleagues say now, can I see in their health records, when people come and ask for a reduction, they say that's against medical advice. And then they have their own back free, but the person is in a very unlucky place because they are going to stop medication, and then they're going to stop medication without our support, and that's much more riskful from my point of view. I have no sense about time.
You're about landing, so...
I'm about landing and survived.
More than that.
The last thing I want to say, I'm landing now. The last thing is about this thinking in psychiatry these days, that we have to detect the very early signs and catch people at an early stage. I'm scared about the side effect of that approach. I could easily have been diagnosed with a psychotic episode when I was 13 and been giving very good support and probably a case manager and being offered antipsychotic medication at that time. And I don't know what would have happened, but I am afraid it could have changed my life into a completely different direction. I'm afraid that I could have had a career as a patient in psychiatry and not as a doctor. So I think we need to talk about, with all this early intervention hype, that there's a side effect to the thinking. We can catch people too early. We can treat them too early, and we can psychoeducate them too reductionistic into this medical paradigm of mental health. And I'm happy to take questions. You can ask me anything. Now I told you everything.
Thank Thank you so much. We have time for about 1 or 2 questions at the most. Maybe people who didn't talk yet. Pesta?
Thank you so much for this wonderful personal presentation, inspiring. I can't help to ask, after the hundreds of lectures which you've given, how did we have the honor of being the ones to give?
Because I'm in a very different place in the world. And because David and I, we happened to talk about my story. And it was, I had a fear that I could be labeled not lived experienced enough with my story. And then I would be too much lived experience to be a part of Skyfist, but not enough to be in the lived experience group. And then I asked David, what do you think? Do you think my story has a value? Do you think has it been important for me? And we started writing, and then this story about how it profoundly shaped me and put me in another position than most of my colleagues. All of a sudden I understood why I often find myself in opposition to them.
Yeah, I just want, first of all, thank you for inspiring the lecture. I would like to ask, when you said that the narrative you possess is not to protect your patient, to be with him.
If they ask for medication that I think will be harmful for them, it's a very, very good question. And at these days I'm getting some experience with ADHD. And I think it's probably harmful for most of my patients to give them Ritalin, because they are quite well functioning in the first way. The way I get around, because it is difficult, because I don't know here, but in Denmark, when we say that now we're going to work as doctors, we have this oath that we swear that we're going to practice in the same way as most of our colleagues. So I cannot deviate too much. So the way I find balance is that I'm very, very transparent about effect and side effects, and about the validity of the diagnosis. And I always say that this is not necessarily to be understood as a disease. I say that to all my patients, even those with psychotic symptoms. I suggest that we talk about this in a way that we talk about what's troubling, what's standing behind you and the way you want to live. And then we describe the problems. In a way like my first psychiatrist did, without giving it a name. And when they ask for medication, I think it's a bad idea. Sometimes I say no, but I have to adhere to guidelines. Otherwise, I can't be a doctor in Denmark. But I think if we are transparent about side effects and about the very, very small effect sizes that people can expect to get, then most people will make choices that are reasonable.
Thank you so much.